My name is Henry Pig.
And I'm Eli Winkleman.
And we are co-founders of Melaknow. I'd like to introduce you to John. John was a husband and a father in his early 50s when his wife noticed an unusual spot in his neck. She begged him to go into the doctors and have it checked out, but John was stubborn, busy, and really thought nothing of the mole. So it was months before he finally went in. When he did end up going into the doctor, though, the doctor said it was nothing and just sent John home. However, just 3 short months later, John was in the dermatologist's office getting diagnosed with stage 4 melanoma. John's not alone. 1 in 5 people will get skin cancer by the time they're 70, and while melanoma accounts for less than 1% of these cases, it accounts for more than 75% of skin cancer deaths. The biggest factor in surviving melanoma is how early it's caught. If caught early, the survival rate is nearly 100%, but this drops off very quickly. Just 1 stage later, the survival rate is only 67%. By the 4th stage, it's all the way down to 14%. By talking to 375 people affected by skin cancer, we learned that there are 2 main problems that prevent early diagnosis. The first of these problems is that primary care doctors lack the training and the experience to properly decide which moles are actually dangerous. They look at these 5 factors, but really it just boils down to, does this mole look weird? They end up sending way too many people to dermatologists because of this, and it results in many unnecessary visits. And if you do go to the dermatologist, you'll experience the second problem, which is that there is a major shortage of dermatologists. Because of this, many areas are undercovered. 1 in 5 regions in the US have 0 dermatologists. So depending on where you are, it could take up to 6 months to get an appointment. This is an overwhelmed and inefficient system. Primary care doctors are underprepared to diagnose moles, and dermatologists are much of the time not available. This is awful for patients because they're stuck waiting around for months after the doctor's appointment, thinking they might have a cancer on their arm while they wait for their dermatologist appointment. This is why we created Melaknow.
Melaknow is a screening tool for skin cancers built into a smartphone app. It uses machine learning to help primary care doctors decide whether or not to send a patient to the dermatologist, saving patients time, money, and worry. There's 3 main parts to Melaknow. We built a screening app that the primary care doctor can use to take images of moles and get back risk assessments. We are using a dermoscope, which has a lens and a polarized light that lets us take higher quality images and get more accurate risk assessments. And lastly, all of it is backed up by a deep learning cloud API, which we specially built to analyze skin lesions. It does all the heavy lifting so the app can be dead simple to use. Let me show you the app. For doctors, it's as easy as point and assess. You just put the phone over the mole, you hit the camera button, our app will automatically take 10 images of the mole, send them all to our server, and give the doctor back a single risk analysis. So this is the 3rd iteration of the app. Henry's been working on it since we won the Congressional App Challenge back in the fall. So that's the app. Let me walk you through how the AI assessment model works. So the core of the assessment model is a neural network that we trained using 10,000 images of different skin lesions. We tested it on 600 images it had never seen before and found that it was 80% accurate. This is amazing compared to primary care doctors, 56% accuracy. So we take all of the images from the smartphone of the mole, we run them through the neural network, and we get classifications of either benign or malignant. And we combine all these classifications with the user's risk factor to get a final risk assessment. And all of this is implemented right now with the exception of the user risk factor and running on an AWS server connected to the app. Additionally, we're proud to say that since yesterday, this model is also patent pending. There's a copy of the patent in your guys' folders. One really cool thing about this system is that we're not just taking 1 image to make our analysis, we're looking at many images. Think about it like this. Before having a procedure like a biopsy done, you would want to have a 2nd, a 3rd, a 4th dermatologist's opinion before going under the knife. By looking at multiple images, we're able to leverage the effect of having multiple opinions without going to many doctors. So for this reason, we like to say that using Melaknow is a little bit like having 100 dermatologists in your pocket. So we've shown you what we built, and who is it for? We talked to three main groups of potential customers: dermatologists, people in the streets, and primary care doctors. Dermatologists weren't interested in using Melaknow because it replaced part of their practice. People on the streets weren't generally that worried about having skin cancer. However, they had been referred to their dermatologist, and they did worry quite a bit. We followed this lead to primary care doctors and found that many of them were not comfortable in their ability to assess moles, and they would use a tool that would assist them. There's $8.1 billion in spending each year in the US on identifying and treating skin cancers. This is mostly in reimbursable services by insurance. We don't want to have to deal with reimbursables initially, so our service available market is composed of groups that can offer a non-reimbursable service. This is primary care doctors, home aides, and nurse practitioners. We're going to primary care doctors first because they have the clinical experience and the decision-making capabilities that allow them to adopt new and innovative products like Melaknow. There's three main segments of primary care doctors based on where they work. So small clinics, there's large clinic groups and on-demand care groups, and closed network insurance companies. Going to primary care doctors first is important before going and getting reimbursable codes, because it doesn't matter how many CPT codes there are for our service if doctors aren't performing. We talked to Dustin Taylor, the Vice President of Network Management at United Health Network, and he confirmed that if we get doctors to use it, insurance companies will likely follow suit. This is because the doctors can validate the effectiveness and usefulness of the product, and the insurance companies can follow. So we're focusing first and foremost on making something that primary care doctors will love. They care about two main things. They want something that's designed for them, not something that's built for consumers, but also not something that's only built with dermatologists in mind. Additionally, they want immediate results that they can use to take appropriate actions with patients, not long-term tracking that's time-consuming for the doctor and the patient. And while there are other software solutions that attempt to tackle the early diagnosis problem, none of them have these two key characteristics. Take DermEngine, for example. It revolves around full-body imaging, which is time-consuming and unnecessary for a primary care doctor to do. Additionally, an analytics system is essentially a Google similar image search. And for primary care doctors who don't have much experience with skin lesions, this doesn't necessarily give them the information they need to make the right patient decision. We think Melaknow can give immediate results because, as I said before, we tested on 600 images and it was 80% accurate. But this isn't the whole picture. There's two key metrics that matter. The first is the false negative rate. This is how often dangerous skin cancer is predicted to be safe. Melaknow had a false negative rate 4 percentage points lower than primary care doctors. But where it really shines through is the second metric, the false positive rate. This is how often lesions that are safe are predicted to be dangerous. Because there's so many safe lesions, even a small false positive rate can overwhelm the dermatological system with unnecessary appointments. Melaknow had a false positive rate 18 percentage points lower than primary care doctors. These two numbers together mean that it can help avoid many unnecessary visits without increasing patients' risks. And avoiding unnecessary visits is important because they can be very expensive. Just going to the dermatologist can cost anywhere from $20 if you only have a copay to $200 if your specialists aren't covered or you're forced to go out of network. And if they do decide to biopsy, that could cost anywhere from $100 to $1,000. That's with insurance. With Melaknow, it's a lot simpler. It's $20, you get all your moles screened, you can do it right in the primary care doctor's office. You don't have to wait around months to get to the dermatologist's office. We make most of our money through this patient screening service, but we also offer custom app development and integration service for large clinic groups and closed network insurance companies. This means that we'll build custom UI for their version of the app, set up custom support lines. There's an example of what this looks like in your folder, as well as integrate with their electronic health record system to provide doctors with custom reports of each analysis that's run. And lastly, we have the Dermascope, which is passed through at $300. To get this to primary care doctors, we're reaching small clinics through three main channels. Web and media platforms, medical supply distributors, these are large companies like McKesson or Baxter that supply most of these small clinics and will partner with third parties to offer products that they don't make themselves. And lastly, teledermatology programs. So teledermatology programs connect dermatologists with primary care doctors in rural areas with few or no dermatologists to offer their patients a higher standard of skin care. These are the patients and doctors that need something like Melaknow the most, and this gives us a channel directly to them. And then for on-demand clinic groups and closed network insurance companies, we're going to be reaching them directly through salespeople because the onboarding process is a little bit longer and more complicated, and we need the direct contact that only salespeople can provide. We're targeting 10,000 primary care doctors over 5 years. This is a $20 million revenue opportunity. We're starting with small clinics and then adding in some large clinic groups and closed network insurance companies just in the last 2 years. It's a really capital effective model because we're a SaaS service or priced like a medical service. So to get to 10,000 primary care doctors, we're starting with local Portland area clinics. We're onboarding them directly by hand, automating the process and exporting it to other urban centers. Once this is done, we're going to open up our cloud server for other groups like teledermatology services to use. This will allow us to reach a large number of those rural clinics in a very short amount of time. And lastly, once we have the resources, we're going to start going after large clinic groups and insurance companies one at a time. For example, Kaiser. Melaknow would be nothing without our highly skilled team. Henry built the app, I built the analysis system, Noah worked on a specific part of the system, Annika built much of the slide deck, Andre built marketing materials like the website, and Hayden talked to 300 people who had been affected by skin cancer. Additionally, we've put together a group of advisors that are in this space, and many of whom are waiting to use Melaknow. For example, Dr. Baskin, a clinic owner and MD in Portland, or Dave Sanders, who is the CEO of ZoomCare, a large clinic group in the Northwest. We've come a long ways, but to put Melaknow to use, we're going to need FDA approval. We've worked with our advisors to start putting together a plan to get this done. The first step is we need to complete our algorithm. So there's a couple things like the user risk factor that still need to be implemented. Once this is done, we can do clinical testing to prove the effectiveness of the product more completely. And then we can submit a 510K and get FDA approval. To set ourselves up for clinical testing, we put together a beta testing network. These are providers that will use Melaknow in their clinic to provide us with valuable performance data we can use to improve it. I started this story with John, and we're going to end it talking about my grandmother. A month ago, I was sitting with her, telling her about what we were working on, and she turns to me and says, "Oh, a mole's like this one," and shows me this black mole, nearly the size of a dime, that she said showed up only 3 weeks prior. I had Melaknow look at it, and it said it was probably malignant. So 2 days later, she went to her primary care doctor. They agreed, and it was removed. We couldn't save John, but we could save my grandmother, and we might be able to save you too. If you have any moles that you're even a little bit unsure about, come see us now or tomorrow at our Maker Faire booth. We'll check it with Melaknow. Thank you.
So we have to ask the question, what's your connection to this? How did you come up with this? That's number one. And number two, how much of the software did you write? You've got Bayesian theory back there.
So my mom's actually a dermatologist, so she's noticed that problem a lot. And about the software, we actually wrote all the code ourselves, except for we used a TensorFlow library for the, if you know the Python stuff, that's a library that has machine learning.
Right, so you cut and paste that in, and then, okay, yeah, right.
Yeah, so for the machine learning algorithm, some of it is out of the box, but there are unique components which we're using, which is what we're patenting.
And a quick follow-on to that, I'm getting lots of questions on this, but then will it get better as you run 100,000 samples through? And is there, because of the Bayes theorem, I mean, it tells us that there's a finite point at which it's not going to get much better. It's an asymptotic curve, basically.
Yeah, so it can only get so good, but it should be able to get like above like 95, 96, 97%. And with the training, we can improve it over time if we're collecting the right data, which is what we're working on with the beta testing system.
This was incredible. Congratulations. So, are you building a company around this? Are you guys serious about
Yes.
this further? A few things. I've actually invested in a few businesses in Slovenia. So I think your targeting is absolutely spot on. I mean, you don't want to go to the dermatologist, you don't want to go to the ENT, you're going to the primary care guys. That's spot on. The image quality, right? How important is the image quality to the diagnosis?
Yeah, so I noticed when you were using it, you had it pretty far away from the skin, so it actually works right on the skin. So it's pretty important that the image quality is accurate, because I'm pretty sure you got all of it on that one.
Yeah. No, not because we are looking at an eye care company, and the analysis is as good as the quality of the images.
Yeah.
So you have to, I guess the primary care guy knows how to take the images.
Yeah, so we're gonna, of course, bring it with instructions. So
Yeah.
it's pretty easy to
Do
operate.
you actually need FDA approval for this?
We talked to a few people and they said we don't need it, but it would be good to.
Because I
keep it
don't
safe.
think you necessarily need it to go to market. Kind of a lab approval, a FDA approval should be enough. But I don't know what advice you got.
So we've looked through a lot of FDA documentation and talked to several people in the regulatory space. And some people have told us we can probably get away with putting it to market, but like as regulatorily, it should be approved.
Yeah. Anyway, we can talk about
I think a 510 would be